This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
ANZJOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
Welcome to Talking ONG, a podcast from the Royal Australian and New Zealand College of Obstetricians and Gynecologists, or ANZJOG. In each episode, we delve into ANZJOG guidelines and research published in the Australian and New Zealand Journal of Obstetrics and Gynecology, ANZJOG. But we don't just summarize, we unpack what these insights mean in practice and how they're influencing real-world care across Australia and Aotearoa, New Zealand. I'm your host, Dr Nisha Khot. I'm an obstetrician and gynecologist based in Victoria, and I lead the ONG department at Peninsula Health. I'm also ANZJOG's president-elect. Today, we are exploring intrahepatic cholestasis of pregnancy, which, by the way, is the correct terminology. So let's stop using all the other terminologies we use for this condition. It is the most common liver condition due to pregnancy, yet one that still generates a lot of clinical uncertainty. Joining me today are two clinicians with deep experience in this area, Associate Professor Scott White and Professor Bill Hague. Welcome to the podcast. Scott, do you want to start with introducing yourself?
Yeah, hi, thanks, Nisha. I'm Associate Professor Scott White. I'm an obstetrician and a subspecialist in maternal fetal medicine based in Perth, and I'm also Editor-in-Chief of the Australian and New Zealand Journal of Obstetrics and Gynecology.
And how about you, Bill?
I'm Professor Bill Hague. I'm a British-trained obstetric physician, now in Adelaide, and I lead research in obstetric medicine at the University of Adelaide. In 1992, I founded the Obstetric Medicine Group of Australasia, called OMGA, which later became the Society of Obstetric Medicine of Australia and New Zealand, now known as SOMANZ.
Welcome to you both. Thanks for agreeing to be on this podcast. Let's start with the basics. Cholestasis is something that most of us as obstetricians will come across at some point. Bill, can you actually describe what this intrahepatic cholestasis of pregnancy is and how it usually presents?
Yes, it's a liver condition of pregnancy, and it's a diagnosis of exclusion. You have to make sure everything else is out of the way. But it, like many other cholestatic conditions, characterized by pruritus, usually starting on the hands and feet, but often becoming generalized, and it may be extremely severe. Occurs most often in the third trimester, but it can be earlier, and it's associated with increased concentrations of serum bile acids. It gets better very quickly once the baby's born.
Thanks, Bill. We now have more precise thresholds for diagnosis, Scott. What's the current approach to diagnostic testing and interpretation?
Yeah, so according to the current guidelines, we would test non-fasting serum, total serum bile acids. So the days of fasting are gone, so you can test them at any time of the day. And so we would consider anything under 19 micromoles as normal, and 19 to 39 is considered mild, 40 to 99 we'd consider severe, and total serum bile acids of above 100 we'd consider very severe, and it's important to make that distinction because that's where the risk of perinatal mortality starts to arrive.
And Scott, the reason for testing non-fasting rather than fasting bile acids, where does that come from?
So it's pretty clear that the bile acids will go up with food, but not significantly. And the evidence around the severity of cholestasis is really based in the evidence now on random serum bile acids rather than fasting. So fasting's a pain. You don't need to do it.
That's a really important point for all obstetricians to remember when they look after women with cholestasis. What if a woman presents with itching but normal bile acids? What do we do in that situation?
Yeah, it's important to remember that in some women, the itch will actually precede the abnormal total serum bile acid. So it's not the bile acids themselves that cause the itch, it's something else, but the bile acids are a marker of severity of the condition. So in someone who's got persistent symptoms, so you think actually she probably has intrahepatic cholestasis of pregnancy, it's very reasonable to repeat the testing a week, 2 weeks later if their symptoms persist.
Let's go through a theoretical case study, Bill. A 32-year-old woman presents at 30 weeks with persistent nighttime itching and bile acids of 24 micromoles per litre. What would your management in this situation be?
First of all, I'd want to acknowledge that she's got a problem. She's got itch, and it can be a big problem. But I'd like her to know that the ICP is actually mild at this point. So I'd be following her, watching for rises in bile acids later on in the pregnancy, every 2 weeks probably, because that might impact on management, the timing of delivery and birth. I'd consider using ursodeoxycholic acid for symptom relief if the itch is severe, because there's some reasonable evidence for that, and or using antihistamines or topical menthol cream if it's mild. There's certainly no need for this particular woman you're describing to consider early birth or intensive monitoring at this stage.
You make a really important point there that although the bile acids are 24, which classifies her as being mild, her itching might be quite severe. And so
Correct.
when we say to women, you have mild condition, that doesn't necessarily equate with the symptoms that they have.
That's right. You need to interact with the woman and realise what's going on with her. On the other hand, it might just be very mild and the bile acids might be 50.
Yes, absolutely. And again, that's another important point to consider as well. Ursodeoxycholic acid these days is widely used, but the evidence has evolved. Bill, what should clinicians know about the role of urso in ICP?
Well, it can certainly help, although it doesn't necessarily take everything away from the symptoms, particularly when the symptoms are severe. It can be helpful, and it can help improve liver function as measured by transaminases. But because it's in fact a bile acid itself, it can complicate the measure of bile acids in the serum because it contributes to that. And so that may impact on the risk predictions. It just takes a bit of skill and use of it to know exactly how you're going. So you don't always just want to say, keep increasing the dose. No, that may not be helpful.
That's a really interesting point you make, that actually starting ursodeoxycholic acid might alter your bile acid levels, which is what you're using to monitor how the disease is progressing. A useful tip for people to remember.
The other important thing is that there's good evidence now that ursodeoxycholic acid can impact on preterm birth, reducing that, and particularly in severe cases. What it can't do is, to be sure of, to reduce the stillbirth risk by itself.
Really good points to remember there. Thanks, Bill. Scott, what about alternatives to ursodeoxycholic acid, things like rifampicin?
Yeah, these are medications that you might consider in someone who's perhaps unresponsive to the standard treatments like the simple things and the ursodeoxycholic acid. The evidence base around rifampicin is less strong, but certainly not unreasonable to consider in select cases. In fact, we've got the world expert on using rifampicin for cholestasis here. Bill, you run the terrific trial. That involves using rifampicin, doesn't it?
It does. We're comparing rifampicin against urso in women who've got severe disease and trying to collect women to randomise into that. It's been quite difficult, but we're more than halfway there.
Yeah, so ideally, I guess if you've got someone who's not responsive to standard treatment, they've got high bile acids, then we call Bill and we recruit into that trial. But otherwise, using rifampicin is something to be considered as a second-line treatment.
That's a great trial. Look forward to seeing what the results show us, and hopefully they will, help us guide how we treat women in the future. Scott, the guideline is very good in offering us some clear direction around when to deliver babies based on bile acid levels. What does the guideline say?
So one of the really great things about the SOMANZ guideline as a clinician on the floor has been able to guide our timing of delivery. In the old days, we used to drag these babies out earlier than we probably should for really no benefit and with the risk to long-term neurodevelopmental outcomes for these early-term babies. So these days we would aim in women with mild disease, that's bile acids less than 40, to aim for birth at term, basically according to routine obstetric indications. For women with severe disease, those with bile acids above 40, we might consider delivery at an earlier term gestation, say 37 to 38 weeks. And for those with very severe disease, that's bile acids above 100, where the risk of stillbirth is, that we might recommend delivery for those babies somewhere from 36 weeks, but again individualised according to patient circumstances. And I would only consider delivery earlier than 36 weeks for cholestasis if there's other complicating factors.
That is a real change from what we used to do. We used to be delivering babies at 37 weeks, even when their bile acids weren't particularly high. So this is good news.
Yeah, great news.
It's probably also worth saying that the cholestasis increases your risk of premature labour, spontaneous premature labour. So if they go into spontaneous premature labour, for goodness sake, don't stop them.
Very important point, Bill. Absolutely. Scott, how do you counsel patients around this decision of when to deliver?
Yeah, well, most of the decisions that we make, or most of the decisions that we ask our patients to make, are around timing of birth, are about balancing risks and balancing those risks of stillbirth versus the risk of early birth. And again, one of the really helpful things from this guideline is that the risk of stillbirth is really not significantly elevated now until those very severe cases with bile acids above 100. So under that, the risk of stillbirth really is not significantly elevated above the general population. So obviously it's important to think about a personalised approach, an individualised approach to care for that woman on the basic premise of don't deliver a baby too early unless there's some reason to do it.
And given that cholestasis tends to be recurrent, I know that I've seen a few women who have come to me in their second or third pregnancy since the guideline has been released and have questioned this. Last time I had cholestasis and you, as the doctor, said I should have my baby at 37 weeks, and now this time you're telling me I can wait up to 39 weeks. How does that make sense? But that's where these guidelines are really useful, aren't they?
Yeah, absolutely. And it's good. It should be reassuring for our patients to know that we're evolving in our practice as evidence changes and in line with international recommendations. So they should find that reassuring.
Yes. We'll be back in a moment, but first a quick message from RANZCOG. The RANZCOG annual scientific meeting is back for 2025, and this year we're bringing it to Adelaide. Heather, what do you have in store for us?
Thanks, Nisha. We're really looking forward to hosting the RANZCOG ASM, and from the 18th to the 22nd of October, we would like everyone to join us at the Adelaide Convention and Exhibition Centre for 5 inspiring days of learning, insight and also real connection. This year's theme, From Conception to Curtain Call, reflects the full journey of women's health, with sessions covering fertility and pregnancy to menopause and beyond. You'll hear from the global leaders in the field, including Dr Matthew Leonardi, Dr Laura McGee and Dr Linda Brubaker. Plus, we've got some excellent hands-on workshops planned, and don't miss the gala dinner. It's going to be a chance to network, dress up and unwind with colleagues. You can earn 23 CPD hours for attending the full program.
That sounds fabulous. I can't wait to join you in Adelaide.
For anyone who is wanting to join us, visit ranscogasm.com.au and come visit us in Adelaide.
Looking forward to seeing you all there. Welcome back. We're discussing intrahepatic cholestasis of pregnancy today. Bill, we used to offer routine CTGs and ultrasounds in the past. Has this changed, or should it be changing? Should we be continuing to offer this?
It shouldn't really be routine, because both cardiotocography, CTG, and ultrasound monitoring, they don't reduce the stillbirth risk in uncomplicated ICP. It avoids triggering unnecessary intervention, and you can prioritise the maternal symptom tracking and the bile acid monitoring. That's the thing to look for.
That will be such a huge relief to women who used to be asked to come every week to have CTGs and every 2 weeks to have ultrasounds. To not have to come to hospital for all of these interventions is really great. Let's bust some myths. Scott, what are some of the common misunderstandings that you still hear?
Yeah, these are the things that we used to consider as routine based not on great evidence, but again, the SOMANZ guideline has really provided good clinical practice guidance for us here. So I've got 3. So the first is that everyone with cholestasis should be delivered early, and as we've discussed, that's clearly not the case anymore, with the risk of stillbirth really being confined to those with the really very high levels of serum bile acids in whom we would consider bringing that baby on a little early. The second being that you have to fast for your bile acid testing. Fasting while you're pregnant is a pain, and it really doesn't change our clinical management with new guidelines, so that's something that you can safely avoid. And again, that CTGs will pick up impending stillbirth. So it's very clear that the mechanism of stillbirth in babies whose mums have got cholestasis isn't chronic, it's not placental, it's not hypoxic, it's acute, and something that CTG won't pick up. And the only outcome from doing CTG monitoring is harmful in that it triggers early birth in a proportion of those women who could safely have been left pregnant.
Thanks very much, Scott. Now, before we wrap up, what's one clinical pearl you'd share with our members and trainees? Bill?
I think you should use bile acid measurements to guide care, but not fear. Really helping women to feel comfortable that they're being looked after well, rather than scaring them.
Scott?
Yeah, I agree. I think that's a great point, that we use these tools to make the diagnosis, but to provide reassurance rather than fear. And that most cases are mild, and most women will do well with reassurance, with symptomatic treatment, and with careful and measured follow-up.
Thanks to Associate Professor Scott White and Professor Bill Hague for your insights today. You can find the executive summary of the SOMANZ consensus statement on ICP in our show notes and the full statement on the SOMANZ website. We've also linked to a valuable ANZJOG paper by Associate Professor Scott White. We'll be back soon with more Talking ONG, exploring the clinical issues, guidelines, and research that matter to our members. If you enjoyed this podcast, please rate, review, and subscribe, and share it with a colleague. It all helps. And remember to log this episode for continuing professional development.